Hi, Michael Sherman, Harvard Pilgrim, and pleasure to be here. And I see many faces who I deal with regularly trying to figure out how do we work together to solve these problems. My job, in a nutshell, is to manage the quality and value of the $2.6 billion we spend every year on healthcare. And the issue is less about the value of many of these drugs. There are some terrific drugs out there, but the problem is that we now are spending about 25%, that's our data 2015, on drugs. And that category is going up very, very quickly, faster than everything else. And the issue is that when we see those, I see some skeptical looks here. There's facts and there's alternate facts. I won't speak to others, but I do know our data because we measured it. And the fact is, I don't know if 25% is a good number or a bad number. If we see more gene therapies, curing cancer, treatments that are effective and matter to patients, maybe it should be higher. We don't need any more $6,000 treatments for toenail fungus. I know Super Bowl ads are expensive, but we don't. And the issue is when you hear about these terrific treatments, we worry about affordability. Someone asked what keeps me up at night, it's affordability. So when you have a new cystic fibrosis drug, again, works on many people, life transforming, I think of that as terrific, but that's 1% we've got to add to our premium request for next year. Hep C, 1 to 2%. So the issue is unless we can figure out how to work together to make sure that what we pay for drives value, we're heading for a crack up. On a positive, and I hope we get to speak about this, a lot of the work we're doing, I take a lot of pride in this because we have a great team. We're working with many of the pharma companies here to figure out how do we put together agreements which pay more when drugs are effective and less when they're less effective, just like we're doing with the rest of the healthcare ecosystem. So I think that's an opportunity.
So it's 25% just for pharmaceuticals? That's not devices, that's not it. What are you rolling into that?
That is the drugs paid under our pharmacy and medical benefit in 2015. And it excludes, because it's hard through DRG contracts, et cetera, we're not sure, it actually excludes drugs given in hospitals. The other fact I'll give you is over the past, I looked at this from 2011 to 2015, the patient cost share dropped on average from 34% to the low 20s, meaning that most of these expenses were spread among the population, not individuals, because we all have in common wanting people to fill their prescriptions, get the drugs they need. And above a certain point, if things get too expensive, they're not going to fill their prescriptions or take their drugs, which is kind of the point, right?
You said the cost share just for pharmaceuticals or overall?
For 20, sorry?
The cost share just for pharmaceuticals?
I'm talking about the cost share for drugs, for pharmaceuticals. Okay. Has dropped in terms of the average that people are paying. So in other words, the cost went up. What they're spending out of pocket for an average individual has been pretty constant, and all of it has been absorbed, which means, and put differently, put into premiums, so everyone's paying for it.